Robin Gelburd, let's get her to the stage. President of Fair Health, coming all the way from New York City. Thank you for being here. Let's give her a round of applause. Thank you.
Welcome, everyone. And I really appreciate the invitation from DJ. It's thrilling to be in Alaska. I love the outdoors. I love hiking. Being surrounded by mountains to me is glorious. I tackled Flat Top yesterday, and so it feels like I really had a taste of Alaska. And it's great to see in person so many of the people we've been talking to long distance by phone. But I think we have another mountain to tackle, which is the healthcare system and the complexities that we've all been grappling with. So it's really a pleasure to introduce you to Fair Health, which is a really unusual organization. I don't really know of any other like it because we were created back in 2009 out of an investigation by the Office of the New York Attorney General into the data that were being used to adjudicate out-of-network claims. There were concerns about conflicts of interest in the data, and indeed the matter never went to trial. It was agreed that it would be settled for approximately $95 million. And what's unusual is that out of that settlement, it was agreed that a new independent not-for-profit should be created that could be trusted, that could create a new data repository with robust claims that are geographically rich, that are current, and that were informed by the best thinking of statisticians and economists in the way in which the data were audited and validated, and to use that data to populate data products, benchmarks, custom analytics, and really ways in which people can take that data and use it in actual operations. Also, we were tasked with launching a free consumer website that could really bring visibility into the healthcare system for consumers, really provide, in a sense, the driver's ed that they would need to navigate the healthcare highway, if you will. And then lastly, as a 501c3 independent not-for-profit, we were really tasked with working with policymakers, federal and state, think tanks, researchers, really giving them the tools they need to really noodle through the tough questions in the healthcare system today. So we sit in a very unique place. First of all, even though it was a New York investigation, it in effect gave rise to a national remedy because overnight we inherited a national data set that supports the entire country. And we're really, in a sense, in the middle of the schoolyard, unbiased, conflict-free, working with all stakeholders, really creating almost like an oasis out there that everyone can work with data to be trusted. So what do we have, and why are people deriving benefit from the data? We have over 26 billion records. This is private claims data, so different than when Valerie was speaking about the Medicaid program. This is commercial data, both fully insured and self-insured, and it's medical and dental, and it dates back to 2002 to the present. It reflects the healthcare claims experience for approximately 145 million medical covered lives and slightly over 60 million dental lives, some of which obviously overlap because we have medical and dental insureds together. And that data then gets organized into 493 discrete healthcare markets to really create that granularity to reflect the unique characteristics of many different areas that have that sort of special heartbeat. And in Alaska, we have actually 5 geozips, which tend to track with the first 3 digits of a zip code. And we had the privilege of working with the Department of Insurance officials a couple of years ago to actually refresh and revisit the geozips, likewise working with an academic independent economist to help in assisting the design of the geozips. And as you can see, compared to Medicare, which is a single geozip, it provides a bit more granularity. In addition to the commercial data that we house, CMS designated Fair Health as a national qualified entity, which means we've now been entrusted with the full collection of parts A, B, and D data for the entire country. And that really is a privilege for us because we are able now to make really interesting comparisons and studies utilizing both the public data from the Medicare set with the commercial data. And so interestingly, even though it was an investigation that grew out of out-of-network reimbursement issues, it soon became apparent that the private claims data, in effect, were like the cream for people's ice cream to really do so many different other things, really, whether it's strategic planning, market research, coming up with different types of reimbursement models, whether it's ACO models or bundle payments, reference pricing, creating epidemiological heat maps, looking at consumer literacy types of programs and so forth. So it soon sort of proliferated in terms of its application. And also because of our independence and the breadth of the data, many states started approaching fair health and incorporating our benchmarks directly into state-run programs involving, the health system, whether it was workers' comp programs, where we serve as, or help inform the fee schedules for many different states, or auto liability. All the purple-colored states on that map reflect areas where we're either certified in some fashion, built into a statute, or consulting and assisting states design statutes, regulations, and just helping them, giving them the raw ingredients to make their decisions. We come with no bias. It's really the stakeholders in the state that make the decisions about how they want to use the data. There are many different states, as you may know now, that are really grappling with consumer protection laws. That's the situation where consumers have been exposed to unexpected bills for out-of-network services or bills for emergency services. Everyone agrees the consumer should be taken out of that equation, held harmless to their in-network amounts under their benefit plans, and allow the providers and the plans to come up with some equitable solution for reimbursement. New York and Connecticut already reference and use fair health data in that reimbursement solution. Over 25 states have come to Fair Health asking for test files for some guidance in ways in which they can design fair reimbursement practices. Some of them are looking at percentiles of billed charges. We also have the allowed amounts, the negotiated amounts, and some are looking at that as a form of reference point. And interestingly, with the in-network negotiated amount, what's fascinating is now that there's been so much state activity in the different capitals around the country, all these different living laboratories. The federal government has now, there is a bipartisan group of senators who are working on a draft bill. You may have read about it. They've come out with a draft piece of legislation to try to address the surprise billing situation where states have not acted. And in there, they already have a proposed standard using 125% of the median of the allowed amount, which is a different approach, referencing a database from an independent entity unaffiliated with any insurer, and that is intended to be Fair Health. And curiously, in that bill, they expressly disallowed the use of Medicare or Medicaid as a basis for reimbursement because they feel that particularly those are sort of policy-based schedules, and in the case of Medicare, for example, there are many gaps that don't cover a number of services, and because it was intended for a certain population that they deem would not be appropriate in this sort of general health environment. So again, they're not looking at charges. In that instance, they're looking at a slight multiple of the allowed. So in this ocean of claims that we have, we really feel it's important to bring visibility to that and allow people to work with the data and have it not be this opaque ocean. So in effect, we like to go out what we think of as on a glass-bottom boat on that ocean of claims and deliver feedback on what we're seeing. Sometimes we feel like the canary in the coal mine because we can see trends emerging that we really feel should be shared with the public. And sometimes it either validates suspicions about changes underway, or sometimes we're able to peel back the curtain and provide some insights about what's going on in the country. And one of the things, and I'd like to share some data we have on Alaska, because Alaska is a unique environment, and there are some things that you'll see are different than what's going on in the country overall. So one of the things that's become quite apparent to us by the billions of claims that we've collected is that there's a real, in effect, almost like a revolution underway in where people are accessing their care. We're seeing huge spikes in claims associated with alternative venues such as retail clinics, with telehealth, with urgent care centers, with ambulatory surgery centers, and more care being done in a home health setting. And so we've been tracking that, and it's not just that there's increasing volume in the number of claims, what's happening in those venues is changing. So whereas before you might have seen with retail clinics, the large majority being associated with vaccines, shingles vaccines or flu shots and so forth, what we're now seeing are really increasing numbers of claims associated with office visits, like 99213, 15-minute office visits, 30-minute office visits, basically getting your primary care through the retail clinic, which may explain, part of the motivation behind the CVS Aetna merger, because people are recognizing retail clinics may be coming in and filling in the gaps of being a part of that sort of primary care ecosystem. So in Alaska, what's happening with retail clinics? As you can see, there was a spike in 2014. It seems to have dovetailed with a program with respect to Walgreens, that there was a huge number of vaccinations. There seemed to be an interest in having diphtheria, tetanus, and pertussis vaccines administered, and that seemed to have been successful, so that explains the spike there. But then you can see there's a slight drop-off compared to what's happening nationally, national being the yellow line, the blue being Alaska. Then we thought you might be interested in seeing, in terms of urgent care centers, what the diagnoses are that are most likely to present. We took the top 15 diagnoses that account for slightly more than 70% of all of the claims in Alaska for that service. And as you can see, acute respiratory infection tops the list, with abdominal pain and associated conditions next, with general signs and symptoms. In the yellow box, you can see how that tracks against the top 3 nationally. So the first one is aligned with the national, as well as your third is the number 2, and injury to the body would be the 3rd nationally. But this is where it's really interesting. If you look at the blue, which is Alaska, versus the yellow national, look at the age cohorts of who's really most commonly using urgent care centers. It skews much higher in the 50 and older in Alaska, much more than national. And the national really reflects most other jurisdictions. And that is not uncommon, because nationally, and it's confirmed by a lot of the consumer surveys we've done, as you're skewing older, most people really have a strong attachment to their primary care professional, are not accessing urgent care as much. The younger cohort, millennials and so forth, who either do not have a very strong relationship yet with a practitioner, or are trying to fit in office visits in between work and are looking for more convenient hours, that's who would typically use the urgent care center as reflected on the national chart. So you can see Alaska is somewhat different there. In terms of usage overall, there's been 147% growth between 2013 and 15 in Alaska, and it seems to have sort of plateaued and is now just sort of leveling off, whereas you could see nationally that trajectory continues to rise. Emergency room usage in Alaska, while it has increased from 2009 to 2017, it has increased at a lesser rate than what we've seen overall nationally. But this is interesting too, and this may explain why the emergency room usage is not growing as dramatically. If you look at the same diagnoses, we took the top 18, which again accounts for about 70% of the claim lines. You could see there's a lot of similarity in what's presenting in the emergency room and the urgent care center. So it looks as though a number of those types of diagnoses may be peeling off and going to the urgent care center. Look at the national number 1 basis for people going to the emergency room, which is cardiac events. Interestingly, that falls lower on the scale in Alaska. This is the other really interesting thing. Look at the age cohorts here, looking at the blue Alaska data compared to national. Again, 50 and older, notably higher than what you would see nationally, really quite significantly higher. And that raises some interesting questions and that's, in some ways, that's what's fascinating about the data, because it's almost handing the baton to the next researcher or the next question. Sometimes we'll peel the onion further. Other times researchers or policymakers will run with the data and really start asking some really deep questions. Why this is occurring? Are there problems with access where people are going to the emergency room because they don't have that sort of ability to get the primary care that they need? I think there's some really interesting questions behind that data. We were surprised a bit at Fair Health about these numbers because telehealth is really growing dramatically in the country overall. As you could see, over 300% increase just in the last 4 years. Alaska, while again, there's a notable increase, 180% is not insignificant. Alaska seems like a prime area where one could take advantage of telehealth if there are, given the vast distances that you have, there may be challenges with certain specialties immediately available. So it was interesting to see that difference. The other thing that's notable in Alaska, when you isolate the claims with a place of service of telehealth, predominantly it's mental health diagnoses. And as you could see, we took all of those diagnoses associated with behavioral health and ranked them. And I want you to keep an eye on the number 2 there, the attention deficit hyperactivity disorder, which is true in Alaska. The yellow box, I should note, mental health diagnoses were not the highest nationally. It was more acute respiratory infections. But we did take out the mental health diagnoses nationally just to compare to what's happening in Alaska. And you could see the top one nationally involves more substance use disorders, major depressive disorders number 3, whereas it's number 1 in Alaska. But again, keep your eyes on the ADHD because that explains this. So when you really try to sort out the cohort in Alaska who are most frequently using or accessing telehealth, it's interesting that it's 0 to 18. That's very different than around the country. That probably ties very much to the prior slide showing ADHD. So you have a lot of young teenagers and children utilizing a telehealth service to treat ADHD. The other thing that is true and that we found in terms of increasing frequency of claims in Alaska, and that seems to be a very purposeful and well-intentioned effort on the part of the policymakers here to attract more professionals, healthcare professionals, into the state. It seems like there were concerted efforts to try to entice more healthcare professionals here. And as you could see, those efforts seem to have been successful. When you look at the CMS provider counts, there are notable increases in all categories. Physical therapy is particularly noteworthy here. You could see on average, there's been a 53% increase from 2015 to 18 in the number of physical therapists. So when you look at your healthcare expenditures, you really have to keep in mind and separate out what, in terms of increased costs in the healthcare system, what's due to increased utilization, which seems to reflect more access to professionals versus unit costs and what's attributable to that. But looking at the unit costs, we look at physical therapy in Alaska, and we looked at the common 15-minute intervention, and we looked at it over from 2015 to 18 in all of the different geozips. And as you could see, there's not that much difference in terms of the charges, the 80th percentile charges in the individual sessions, except in 999, which is Wrangell and Ketchikan. You see the jump from 43 to 75, which is still tracking lower than the other geozips. But again, the volume has increased, but the individual unit charges did not. Similarly, in emergency room visits, again, looking at a visit of high urgent severity, in 995 in the Anchorage geozip, again, from 2015 to 18, the blue line reflects frequency. So you could see there's been a jump in the number of actual encounters in the emergency room. But in terms of the 80th percentile of bill charges, not overly dramatic. Here's the 15-minute office visit, one of the most commonly billed codes. Again, the 80th percentile here, and you can see this is in the different geozips. Tracking the black line shows frequency, so there has been an increase in frequency. But in terms of the actual pricing on a per unit basis, not dramatically different. We thought it might be helpful just to see a different kind of view. As I mentioned, there's been an interest in trying to reach some compromises about how different services can be reimbursed, particularly when it's in the surprise bill setting or if in out-of-network setting. And whereas people have moved away from Medicare, they're thinking, what are other options? There, of course, is the 80th percentile, but there are many other percentiles. You can go to the 50th, the 60th, the 70th, but they're also, as I mentioned in the federal bill, they're looking at 125% of the median of the allowed, the negotiated amount. So here's a juxtaposition of the 80th percentile of billed charges for office visits against that 125% of the allowed median in Juneau, 998. And this is just taking another view of emergency room visits in Juneau, again juxtaposing the 80th percentile against that 125% of the allowed, the median. Again, just to give you a sense of the relative relationship of those values. I know Valerie had mentioned the opioid crisis earlier. We've done a lot of work in the opioid space, and one of the things and ways in which states drive value from the data that we have is that because it's national in scope, you could really see that geographic tapestry, what's happening around the country. We did some work, and they're all on our website, free, at no charge. There were 4 separate opioid white papers. The last one took all 50 states, and we identified what are the 5 most common treatments or protocols in a state for someone with a diagnosis of opioid abuse or dependency. And we likewise isolated the top 5 protocols that are the highest cost centers, the most expensive. And what we found when we looked at all 50 states was a dizzying array of different approaches to opioid abuse and dependence. And it's fine for states to be their own laboratory, but again, there's this sense that no one's looking over the fence at their neighbor. It's unclear. People are not sure what best practices are. And as you can see here, we just took Alaska, Montana, and Idaho just to give you a flavor for that variation. When you see the same color in each column, that's where there's commonality of a procedure. It may not be ranked the same. So you could see 99213 is in everyone's column. But after that, you could see testing for the presence of a drug in Alaska is only apparent in Idaho. And they're at different levels. The gray means that there are no matches anywhere as between those 3 states. So those are unique to the states. This goes to aggregate costs for the procedure. Again, you can see that there are a number of instances where there's variation. So one of the things that people have asked for us to do is to see if we could start evaluating what the outcomes are from these different protocols. We will track cohorts in the various protocols, whether it's partial hospitalization, intensive outpatient, methadone maintenance, naltrexone, to see who's relapsing, who's really having overdoses. If we can glean some information from this very varied tapestry, as I said, that exists. Here, Alaska, again, somewhat unusual. And this is, again, where you want to pass the baton or where we like to look further. So this is, again, breaking it out by age cohort. You could see that Alaska notably has 50 and over to be the largest cluster of claims associated with opioid abuse and dependence as compared to Montana and Idaho. And then again, what would be my next area of interest, and these are the things that we look at, if you took that 50 and over cohort in Alaska and you look backwards, how many are coming out of a surgical procedure? How many maybe would be really had been prescribed opioids and are then just continuing and develop the opioid abuse and dependence after? It would be a fascinating study. The other thing that we just did recently, the Bureau of Labor Statistics licensed our data to help develop their medical CPI indices. Prior to that, the reason they came to Fair Health is we had released our own in March of 2018, and we broke up the services into different categories. So we did professional evaluation and management services, all the office visits, and then we did hospital E&M, which are the emergency room visits, and we did some other categories as well. Those are released and they're free on our website. What we thought just for coming here is to take Alaska and track it against the national. As you can see for professional E&M, when you look at the median of charges year over year in terms of growth, you're tracking with the national index. And likewise with hospital E&M, very close, pretty much of a negligible difference. It's really when you get into surgery and pathology and lab where you start seeing higher departure between Alaska and the national, and that is probably attributable to the efforts you've made in bringing some more specialists in here with more expensive services and a different sort of case mix. Again, we have all of our infographics at no charge on our website. We do a lot of work in different public health areas, whether it's Lyme disease or pediatric obesity and diabetes, concussions and so forth. And always happy to bring visibility to public officials and public health professionals to help design interventions and educational campaigns. And finally, as I mentioned, we were tasked with launching that free consumer website and have really spent a lot of time and energy working with consumer literacy experts to really empower consumers to be better advocates for themselves as they really deal with, as you can imagine, an incredibly complex healthcare system that even professionals are really struggling with. Thank you.
All right. Robin, thank you very much. I won't burden you with a bunch of questions. I think those were great slides. I know people were texting me, you know, are they on the flash drive? Yes, they're on the flash drive. We're out of time for our lunch keynote. Let me just ask you, as you've looked at all of this data and you've thought about Alaska and you had some time on your flight out and we had dinner and all that good stuff, if you were to tell the story of the Alaska healthcare system to the lower 48, based on the data that you've seen and sort of encapsulated in one description, what would the story of Alaska healthcare be to outsiders?
Well, first of all, what's striking is even when Valerie was explaining where she lived in her town and how you could find it by down the river or what have you, everything is so personal here, which it is just it's so striking. I mean, I feel like it's, while an incredibly large geographic area, you all know each other, and as she said, she's seeing all these familiar faces out there. I can't say I see a lot of familiar faces because I'm a little far from home, but it's really striking how you're all grappling with so many different interests. There clearly is a strong intent to provide access to and good quality care to the citizens here. But you're working in a very challenging geographic environment, and so to really entice and to really bring in the level of professionals that you need, there are certain compromises that probably have to be made in terms of what the billing rates are that depart from the lower 48, if you will.
Yeah.
And so I think there's a real struggle in terms of the payers are really trying to design plans that can meet the needs of the members in a way that have premiums be really manageable for the consumer. At the same time, the physicians and the other professionals really need clearly to be compensated in a way that's fair. So in real time, I see that tension and that struggle in play, and I think there is a lot of good intent amongst the the stakeholders that I've met here, and it seems like people realize everyone has to win a little for everyone to succeed. In terms of a tug of war, no one wants to wind up just in the mud as they pull. Right. I think everyone has to really come a little bit to the middle, which is what we're seeing nationally anyway. But I'm really struck by how you're really trying to grapple with these very unique challenges that are particular to Alaska.
Well, thank you for making this long trip, and thank you. You've been here for much of the morning. I know if you all want to corner her and ask her questions, you'll be sticking around for a little while and here for the duration, certainly in Anchorage. So thank you, Rob. Let's give her another round of applause.